I'm Peter Block at TCT 2018, and here's a question for you. Patient comes in with chest pain and angina, and they go to the cath lab and they don't seem to have anything bad going on. Their coronaries look okay. What do you do now? And with me is Tom Ford from Glasgow, and he's just finished talking about the CorMicA trial. So, Tom, without further ado, this is a fascinating trial, a useful trial for us as interventionalists. Tell us what the trial was and then the outcomes.
Sure. So we looked at stable angina patients that were undergoing a clinically indicated angiogram. And we randomized patients who had no obstructive coronary disease into one of two groups. So we randomized them into an interventional diagnostic procedure, and that consisted of guide wire-based measurements of microvascular function, as well as a vasoreactivity testing with ACH.
Okay, so you used acetylcholine to try and figure this out. And of course, some of these patients had nothing.
That's exactly right.
Other patients had vasospastic angina, and the third group might have had microvascular disease. Am I right on those three?
You're exactly right. So we look at this group of patients with angina, but no obstructive coronary disease, and we consider that some of them may have no cardiac chest pain at all. They might have normal function, in which case their tablets should be safely stopped, their anti-anginal therapy stopped. On the other hand, ischemia related to conditions such as microvascular angina or vasospastic angina are typically not diagnosed in standard care. And these disorders need distinct therapy, and that's really what this trial is about. Personalized therapy for the underlying diagnosis.
Okay, so I come in and I'm lying on the table now, and you cath my coronaries and they're okay, and I tell you I'm really having chest pain and my EKG isn't quite right. So how do you differentiate between the vasospastic and the patients that have small vessel disease?
Exactly. So it's a good question. The differentiation, it relies on the angiogram. So CoVadis, which is the working group interested in diagnosing these disorders, they look at the three criteria for vasospastic angina. Significant epicardial constriction, greater than 90%, with reproduction of chest pain symptoms and ECG changes.
Giving what medication?
With acetylcholine bolus.
Acetylcholine.
Yeah. So the bolus that we use is up to 100 micrograms.
Okay. And what about the patients with small vessel disease?
So small vessel disease can be diagnosed in the cath lab in one of three ways. In our study, we looked at coronary flow reserve, that you'll be familiar with, a metric of the vasodilator capacity of the coronary artery. We look at microvascular resistance with the IMR. And the final component for diagnosing microvascular angina in the cath lab is with ACH. So I mentioned the vasospastic angina needs a significant epicardial constriction, but patients who have microvascular spasm has a distinct disorder altogether. They've got no significant epicardial change on angiogram, but they interestingly have reproduction of symptoms with ischemic ECG changes.
Even though you may not see it.
Exactly. So what you would see typically is slow angiographic flow. It looks like no reflow.
Okay, so there are the three groups. Tell me what you found.
So what we found by stratifying patients' therapy and doing these tests is that we could improve patient-centered outcomes, and that includes angina severity. That was our primary outcome, was the Seattle Angina Summary Score, as well as quality of life. And the sort of degree of change that we noted was a Seattle Angina Summary Score of around 12 units. And that was a regression model adjusting for baseline differences. So quite significant. That translates clinically to an angina frequency of 9 units, which is about probably around 1 CCS class. So really quite significant differences.
Okay, how did you treat them? Calcium channel blockers for those with vasospastic angina, and then small vessel disease with beta blockade?
Exactly right. So we used the ESC guidelines from 2013. They're the only guidelines for stable angina that actually specify treatment for these functional disorders. And as you mentioned, first line treatment for microvascular angina is a beta blocker. We typically avoid nitrates in this group. And there's good evidence that microvascular angina and heart failure with preserved ejection fraction have an overlap syndrome. And we know that nitrates are actually detrimental in HFpEF, and we feel the same way about microvascular angina.
Okay, so the answer is, if you look carefully with all of these tests in the cath lab, you can differentiate the patients, and when you treat them properly, they get better.
I think so. I think personalized therapy and patients, they're seeking our attention to get a diagnosis, and we deserve to give them a diagnosis.
Well, this has always been a difficult group for us, and I'm delighted that we finally have something that tells us that personal care actually makes a difference. Thanks.
Thank you.